Hi there. Thank you for your attention today. My name is Melissa Hershman. I'm an assistant professor at the Oregon Health and Science University in the Division of Gastroenterology and Hepatology. I'm here today to talk to you about amyloidosis of the gut. I have no relevant disclosures to this talk. So to understand amyloidosis of the GI tract, we have to take our magic school bus on a deep dive through the intestine to really understand the different layers of the intestinal lumen. Systemic amyloidosis, which is the most common type of amyloid disease, is characterized by the production of amyloidogenic precursor proteins at a site remote from the organ of amyloid deposition, whereas local amyloidosis, in comparison, is defined by the production of precursor proteins in the same location as the amyloid deposition. Both of these can occur within the GI tract. And the distinction is important because localized deposition of amyloidosis, while it may be associated with symptoms such as GI bleeding, does not necessarily require treatment, whereas systemic disease does or may. GI involvement in amyloidosis is defined by the presence of GI symptoms with direct biopsy verification. And the site of amyloid deposition within the intestinal lumen will affect the types of symptoms involved. So, for example, we can have amyloid deposition within the mucosa, the innermost lining or superficial layer of the intestinal lumen. This is the only layer that we can actually test for directly via sampling. We can also have amyloid deposition potentially in the muscle, which may affect motility and contractility, in the vascular system, which may cause ulceration and bleeding, as well as in the nervous system of the gut, the myenteric plexus, which may be more prominent in amyloid types such as TTR amyloid, where we have deposition into the heart and the nervous systems. And these types may be particularly harder to test for within the GI tract. We'll talk a little bit about what deposition into these different layers might look like from a symptom perspective. So first, looking at the mucosal involvement of amyloidosis. Again, this is the innermost lining of the intestine, and this is really what's responsible for absorption of nutrients, foods, and liquids. And this is the only layer that can be sampled with routine GI biopsies via testing such as endoscopy and colonoscopy. With this in mind, it does require specialized microscopic staining, the Congo red staining, looking for the classic apple green birefringence description to help see this. So providers need to have a high index of suspicion to notify their pathologist to perform this staining when they're actually thinking about or looking for amyloidosis. This is most commonly found within the duodenum of the small intestine, but can be identified in any site along the intestine. Mucosal involvement of amyloidosis might result in symptoms such as malabsorptive symptoms, diarrhea, weight loss, loss of appetite, protein-losing enteropathies, such as severe protein losses resulting in edema and ascites or fluid retention around the abdomen, which may be somewhat difficult to tie apart from cardiac involvement or fluid overload from heart failure, and GI bleeding resulted from ulceration or friable vessels. Vascular involvement of amyloidosis is one of the most common presenting symptoms, and this is certainly something that often prompts endoscopic assessment and therefore may be prompting the GI diagnosis here. Vascular involvement may occur in up to about half of patients with GI amyloid, and the underlying cause is commonly mucosal lesions such as amyloidoma ulcers, erosions, polypoid lesions, hematomas, or submucosal hemorrhages, as you can see here in this image. Can also be associated with vascular friability, as we'll see here in this image, and small ulcerations. And in some cases, bowel ischemia or low blood flow states. Massive occult bleeding from the GI tract is usually seen more specifically with dialysis related amyloidosis. Neuromuscular involvement is deposition of the amyloid proteins into the intrinsic nerve plexus, the myenteric or submucosal nervous plexus, and the muscularis externa, the longitudinal and circular muscular layers of the intestinal lumen. Together, the nerves and the muscles of the intestine control coordination, motility, and pain signaling. So, symptoms of neuromuscular infiltration may involve dysmotility types of symptoms, things like nausea, vomiting, diarrhea, constipation, chronic intestinal pseudoobstruction, or an increased risk for SIBO or SIBO, small intestinal bacterial overgrowth. Again, the nervous system is not an area that we can easily target with biopsies of the intestinal lumen, and therefore we may be missing some of these diagnoses. The liver is also a potential site for GI involvement. Usually, liver involvement in amyloidosis is mild and it requires a very large deposition of amyloid protein for us to start seeing symptoms or laboratory findings related to this. Most commonly, what we'll see is an increased alkaline phosphatase and a liver enlargement or hepatomegaly. Both of these findings, however, are very nonspecific. Symptoms as well may be nonspecific, things like weight loss being most common, fatigue, abdominal discomfort, and anorexia or loss of appetite. Overall, GI symptoms of amyloidosis are very nonspecific, and these symptoms in general can exist in up to 30% of the general adult population. So, symptoms may be related to amyloidosis, they may be related to a medication side effect, or it can be simply an unrelated GI disease occurring simultaneously. The location of symptoms may really be defined on where amyloidosis occurs, or again, where our issues are. So, kind of thinking from top down, problems with mouth and pharynx may include things like macroglossia, enlarged tongue, different alterations in taste and texture, trouble with swallowing, reflux and cough related to the esophagus, heartburn as well. Moving down to the stomach, symptoms may include things like dyspepsia, abdominal pain or discomfort, nausea. When we talk about our small bowel and large bowel, we're thinking more about things like bloating, diarrhea, and constipation. And rectal nervous system involvement may involve fecal incontinence or evacuation disorders. In terms of testing for GI amyloid, endoscopy and colonoscopy is really at the forefront. And what this can sample for is mucosal disease within the superficial lining of the intestine, as well as looking for ulceration, bleeding, and potentially treating these sites. Certainly, while we are looking with our camera exams, we can evaluate for other non amyloid issues such as polyps, Barrett's, other causes of diarrhea, abdominal pain, or gut symptoms like celiac or inflammatory bowel disease. And we can sometimes offer treatments right then and there, such as stretching any narrowing or blockages, removing polyps, or other options at that time. The question really comes into play is how often do we see GI involvement in amyloidosis? And the answer is really surprisingly rare. So, even in patients with known amyloid disease, we're seeing rates of positive biopsies in 3 to 15, 16% based on some studies. Even if you take patients with known amyloid disease plus GI symptoms, one study suggests that less than half of these will still have positive biopsies. So, again, keeping in mind that patients may have negative biopsies because the GI tract is not involved, Or it may be that GI involvement is there, but not present in the mucosa in the lining. And perhaps the GI tract is involved in deeper other layers. For example, like TTR disease, which may be affecting the nervous system and not necessarily the intestinal lining. Looking at these endoscopic findings, this was retrospective review of data from a very large center, and they looked at all of their patients from 1998 to 2011. And this referral center had over 2,000 patients with all types of amyloid that were evaluated. And only 76 of their patients, which was 3.2%, had biopsy proven amyloid in the GI tract. So again, only 3% of a very large cohort. Of these 76 patients, a majority had systemic amyloidosis with dominant GI involvement, but there was also a group of patients, 16 of which were just localized amyloid deposition. Even with the systemic GI involvement, the most common type, which is panned out in other studies as well, is going to be the AL type, lesser common familiar or TTR, other subtypes. In the patients with localized amyloid deposition, what we can see is that there's no other organ involvement. And the most common symptom for finding these patients is going to be bleeding. In patients with systemic amyloid that had GI involvement, most common presenting symptom is usually weight loss followed by nausea. And those patients, of course, being systemic, tend to have other organ involvement as well, most commonly things like neurologic, cardiac, and renal. Biopsy sites can really vary in terms of where we're going to find amyloid and where our sort of best bang for our buck in terms of looking for it is, but typically may involve the stomach, the colon, or the small bowel. And one of the really notable things you'll see here is that the time from symptoms to diagnosis for patients with systemic amyloid, TTR, or other forms of amyloidosis is really long. Patients are waiting a very long time before this diagnosis is accurately made. In this same study, they also looked at what sort of treatments were offered, again, focusing on their larger systemic AL group versus the localized group. And again, as we mentioned, localized amyloidosis does not require treatment. This is just a group that's treated with observation only. Whereas those with systemic disease had a variety of treatments offered, most commonly in this cohort being things like stem cell transplant. And what's important to note here is that patients with treatments that were offered developed a lot of symptoms potentially related to their treatment. So in that systemic cohort of amyloidosis, over half the patients developed diarrhea and a quarter developed GI bleeding, which may be related to their treatments. So not only does the disease itself present with symptoms, but the treatments can also exacerbate some GI symptoms. For cardiac amyloid variants, the variant can actually affect the likelihood of having GI symptoms. The Transthyretin Amyloidosis Outcome Survey, which was the first global and multi-center longitudinal survey of over 1,500 hereditary TTR amyloids and 160 wild-type amyloids patients, found that the hereditary group was much more likely to have GI symptoms, 63%, and certain mutations such as the V30M had even more common rates of GI symptoms, whereas the wild type was much lower. Only 15% of patients had GI symptoms. Those symptoms most common being things like unintentional weight loss, early satiety, altering diarrhea, and constipation, and were more frequent in early onset individuals. Those patients with predominantly cardiac complications did not have higher rates of GI symptoms, however, than the general population. The take-home point here being that we may not always find amyloidosis, and patients with cardiac amyloid may have either GI involvement or symptoms related to or unrelated to their amyloid disease. In this same group, they also looked at what the propensity of GI symptoms was with the duration of disease. And what's clear here is the longer someone has any amyloid disease, the more likely they are to suffer from any GI symptoms. So rates of things like early satiety and other GI symptoms will go up over time. Now, thinking about how else can we test the GI tract, we're really talking about things that are non-specific to amyloidosis. So other types of motility testing, for example, looking in general for dysmotility tests. So looking at an esophagram or a barium swallow, an esophageal manometry, a catheter test to test strength and coordination of the esophagus, or acid tests, such as a Bravo capsule that's employed into the esophagus, and a 24-hour pH impedance. Thinking about stomach involvement and talking about motility issues of the stomach, we're talking about things like a 4-hour solid food gastric emptying study done in nuclear medicine to attest for gastroparesis. Small intestine motility can be performed with things like upper GI X-ray series with small bowel follow-through. And colon motility can be tested through things like SITS markers, where a patient swallows a small pill containing a number of markers, and they have serial X-rays done over the next several days to see how these markers move through their GI tract. Likewise, we can test the motility of the anorectal region by using a catheter with balloon measurements to test pressure, strength, coordination, and sensitivity, called an anorectal manometry. Patients with amyloidosis of the gut may also be at risk for small intestinal bacterial overgrowth related to this dysmotility, related to also things like frequent antibiotic use for infections or other complications. And this may present with symptoms such as bloating that is delayed, usually several hours after eating or the end of the day. Flatulence, diarrhea, fatty stools, and brain fog may result in nutritional deficiencies, particularly B12. And this can be done by breath testing to look for excess levels of gases produced by bacteria, such as hydrogen methane or hydrogen sulfide. Treatment of amyloidosis is dependent. So, local GI amyloid deposition does not itself require treatment, whereas systemic amyloid with GI involvement, treatment is non-specific to the intestine. So, really, management of GI symptoms are supportive care and, again, non-specific to the GI tract and amyloid. But what we know is that systemic treatments of amyloidosis may actually improve the gut symptoms. For example, in the Apollo phase 3 study, looking at treatment showing that there is an improvement in diarrhea over placebo. When we talk about treatments, again, these are non-specific to amyloid. These are really general treatments for patients suffering with these types of symptoms. So thinking from top down, first with GERD or gastroesophageal reflux disorder. Key is going to be here lifestyle interventions, head of bed elevation, no food 3 hours prior to reclining, small frequent meals, and weight loss if appropriate, certainly stopping smoking and reducing alcohol. Thinking about acid suppression with different types of antacids, proton pumps inhibitors, or our newest type of treatment, the PCAB molecules, and potentially surgical interventions in patients that are really refractory to lifestyle and medication therapy. For gastroparesis or delayed stomach emptying and nausea symptoms, again, being one of the more common with amyloidosis, first-line treatment is going to involve things like a small particle diet, which involves small frequent meals, avoiding foods that are high in fats, roughage based, have insoluble fibers, acidic or carbonated beverages, and instead focusing on things like cooked vegetables without skins, mashed and rice puree forms, proteins that are in smoothed forms like hummus, Greek yogurt, eggs, and tofu, and certainly lifestyle interventions, avoiding triggers of inflammation and irritation to the intestine like alcohol, tobacco, and marijuana. Medications that can be helpful for gastroparesis include prokinetics, promotility agents, like Reglan or metoclopramide most commonly, antiemetics, anti-nausea medications, and adjunctive therapies, things that are not necessarily pharmacologic but can actually have great benefit, things like acupuncture, ginger, vitamin B6, and cognitive behavioral therapies. Treatment for diarrhea symptoms involves thinking about treating SIBO or testing for SIBO with antibiotics, trying bile salt agents, things like cholestyramine, particularly if there's a history of a gallbladder surgery or surgery on the ileocecal valve, antidiarrheal treatments, and rarely needing things like octreotide or IV nutrition. SIBO treatment particularly will involve different antibiotics depending on what type is identified of bacterial overgrowth. Thinking about the cornerstone antibiotic being rifaximin or Xifaxan, which is really a gut-specific antibiotic that does not have a lot of systemic absorption, thus lower rates of symptoms and side effects, helps almost as a gut cleanse, and typically is given in a 14-day course with or without additional antibiotics, depending on if there's methane or hydrogen type overgrowth. Alternative antibiotics can certainly be used based on cost and availability. Constipation treatments will certainly involve lifestyle changes like increasing water and physical activity, as well as dietary fiber, in addition to a number of over-the-counter and prescription laxatives. Our most common, perhaps, being Miralax or polyethylene glycol solutions, based on the fact that this is an osmotic laxative with a low side effect profile and is very easily and safely self-titratable at home. For pelvic floor dysfunction or patients with straining, incomplete emptying, or fecal incontinence symptoms, we want to think first about having them bulk their stool using fiber agents and sometimes helping them empty their rectal vault. So that will involve things like digital stimulation maneuvers, rectal suppositories or enemas, pelvic floor physical therapy to retrain those muscles and help work on coordination maneuvers. And in really refractory cases, thinking about colorectal surgery for any anatomic abnormalities. In terms of abdominal pain, there's a number of adjuncts that have quite a bit of evidence behind them. Things like acupuncture, yoga, and cognitive behavioral therapies, diaphragmatic breathing exercises, and peppermint supplements. In addition, there's medications that specifically work on gut nerve pain, which we term neuromodulators. This involves classically the TCA or tricyclic antidepressants, things like amitriptyline, nortriptyline, desipramine, and imipramine, as well as including some of the SNRI medications, antispasmodics, and other medications like Lyrica and gabapentin, which all have evidence support for their treatment in nonspecific GI abdominal pain. Thank you for your attention.